Hello and welcome to this Hopkins at Home session. Tonight, we're going to have a weighty discussion. We have two Johns Hopkins experts with us this evening, and they're going to talk to us about different conditions on opposite ends of the weight spectrum. So let's get right to it. I'd like to introduce to you Dr. Rexford Ahima. Now, Dr. Ahima is the director of the Division of Endocrinology, Diabetes, and Metabolism. He is a Bloomberg Distinguished Professor of Diabetes, and that's across the schools of medicine, public health, and nursing here at Johns Hopkins. He's also the leader of the Johns Hopkins Diabetes Initiative. His research focuses on the pathogenesis of obesity and diabetes, particularly how circulating factors target the brain and peripheral organs to regulate feeding and glucose and lipid metabolism. Dr. Ahima, thanks for being with us this evening.
Thanks for having me.
I'd also like to introduce you all to Dr. Angela Guarda. She is the Stephen and Jean Robinson Associate Professor of Psychiatry and Behavioral Sciences at the Johns Hopkins School of Medicine. She has been the director of the Eating Disorders Program at Johns Hopkins since 1997. She's an active clinician, educator, and researcher. Her clinical research interests include improving treatment outcomes and rates of meal-based weight restoration for anorexia. She is actively involved in neuroimaging research, examining neural mechanisms of appetite dysregulation that may contribute to the driven nature of eating disorders. Dr. Guarda, thank you for being with us.
Thank you. It's a pleasure to be here.
Okay, guys, let's jump right into it. Let's start on the obesity end of the weight spectrum. Dr. Ahima, what is obesity? How do we define that?
So, broadly, obesity is defined as having too much body fat in fat depots, which we call adipose tissue, and in other organs. Often people don't take that into consideration. On a population level, the measure we use for obesity is called the body mass index, the BMI, which many of you have heard about. So a BMI greater than 30 is considered in obese range. Anywhere from 25 to 30, less than 30 is overweight. And anywhere from 18.5 to less than 25 is considered normal. Having said that, again, notice these are just numbers which are supposed to represent body fat. They are not direct measures of body fat. For children, and I should add this very quickly, the definition is a BMI greater than the 95th percentile, right? For the age and sex range of that child. So it's a little different definition. But broadly, obesity is just having too much body fat.
And the kids have to have a different measurement because they're growing at a different.
They're growing, and the girls grow differently from the boys and so on. So that needs to be taken into consideration.
And you said one thing that I thought was interesting about where the body fat may be. The BMI and these 95th percentile for age and sex is not a direct measurement of body fat. And you said that body fat could be in multiple places, including within the organs. So it's not just, the subcutaneous fat that many of us may think of when we think about body fat, but you're saying it could also be in the tissues of the organs and in the connective tissues between the organs. Is that correct?
That's correct. So as you said, subcutaneous tissue is the most abundant site. So women will have 5 to 10% more subcutaneous tissue compared to age-matched men, for example. That's normal. As we get obese, the the internal organs begin to accumulate more fat, and that's called visceral fat. And then deeper within organs, you can also develop what we call steatosis. So the liver can accumulate a lot of fat, and we call that fatty liver. Foie gras, you see that in dogs who are overfed, right? And muscle can overaccumulate. Even the pancreas, where insulin is secreted, can overaccumulate fat. And often this is not healthy fat. It induces inflammation, a bit of oxidative injury, and overall organ dysfunction. And that's why obesity in the long term predisposes to things like diabetes, insulin resistance, even cancer, lung diseases, you name it. Every organ system can be affected because accumulating fat in these wrong places has metabolic consequences.
And metabolic consequences, it sounds like over the life course, right?
Yes.
That the accumulation, that it can be a slow process, but then once you hit that that overweight or obese level, the impact on the body is, an unhealthy state that persists and then gives rise or perhaps a greater risk to other outcomes, negative health outcomes that we all try and avoid, like cancer, like diabetes.
That's correct. And I just need to mention that here we're talking about risk, right? So people assume, oh, why is so-and-so person overweight or obese and doesn't have diabetes, right? There are multiple factors that go in. So your genetic predisposition to diseases like diabetes and cancer also play in. Being overweight or obese just tips you over, right? So there's a risk, and you add on other factors, and that collectively will determine whether you develop obesity-associated diseases, heart disease, cancer, fatty liver disease, and so on.
Fantastic. So we're going to talk in just a minute more about what causes obesity and then what the downstream effects are, as you just noted, that it can kind of tip a healthy body into a place of unhealthiness and then increase your risk for additional downstream diseases that we're trying to avoid. But Dr. Guarda, let's bring you in to talk about the other end of the weight spectrum. What is anorexia?
Well, anorexia nervosa is a psychiatric disorder or a mental disorder that is characterized by what we sometimes call morbid eating restraint, or a drive to diet, to take in less calories than are needed to maintain weight. So in anorexia, the opposite happens in the sense that BMI, for instance, is below normal. Typically, we think of a cutoff, but these are arbitrary. They're not exact. Depends, again, on age and on the person's family history and personal history. But we think of a cutoff of less than a BMI of less than 18.5 as kind of when we start worrying about an individual possibly having anorexia. But anorexia is also a very compulsive or driven behavioral condition, in the sense that it is, in a way, an addiction to starvation, to not eating, which is difficult to understand for most people, because obviously food is a pleasure, eating and consuming food is a pleasurable activity. It's important to the survival of the species, for instance. So, but in it, what you see in anorexia is that patients become very anxious about eating, especially eating high calorie density foods, which are the typical palatable or favored foods, for instance, by children or even by adults. In fact, they're the foods that tend to cause obesity, right? But those are the foods that individuals with anorexia have the highest level of anxiety about eating. So things like fried foods, sweets, fast food, snacks, they tend to cut out carbohydrates and especially fats. And their body fat is the opposite of what you would see in obesity. They lose all their body fat and are often can be very, what we call emaciated or underweight, extremely underweight. And like with obesity, anorexia nervosa has very serious medical complications and can affect, again, all organ systems. So we see this actually is the second most lethal psychiatric condition after opiate use disorder. So death rates from anorexia are high, given that this is a treatable, not a terminal condition. But the problem is that patients are scared of the treatment. It makes them anxious and they tend to avoid it. And the behavior is very driven or compulsive, typically not eating and often exercise, which is present in about 80% of patients. Now, one thing worth mentioning is that some patients with anorexia may also intermittently binge or lose control and overeat and purge by vomiting or use of laxatives. So the distinction between anorexia and bulimia is actually one of weight, not whether someone is binging or purging. If someone is underweight, the diagnosis of anorexia will trump the diagnosis of bulimia. So that's kind of an important distinction that people don't often understand. They think that anorexia means restricting your intake and only exercising, but it can, some individuals with anorexia may also have binging or purging behaviors, but they can, overall, their net energy balance is negative and therefore they're underweight.
So let's pause for a minute there before we dive into these kind of drivers of these two different conditions, obesity and anorexia. You had noted that, Rex, you said over 30 BMI is obese. And Angela, you noted under 18 and a half is underweight, severe underweight. So this BMI scale is clearly important when we're talking about weight and how we characterize and classify weight. But you both also noted, these are numbers on this measurement tool that we have, and it's not perfect. So there must be some challenges in really diagnosing or classifying individuals with obesity and at the other end also with anorexia or severe underweight conditions. Can we talk a little bit about that? How do you work with that? Is this something that a clinician really has to take into consideration when diagnosing an individual level? And then also from a researcher perspective at the population level, what do you make of studies and how do you kind of interpret studies and particularly maybe effects around those cutoffs that are so critical in our BMI scale, greater than 30 for obesity and less than 18 and a half for anorexia? Rex, do you want to share your thoughts on that?
Yes. So the BMI concept really goes way back into maybe a couple of centuries ago when a Belgian statistician, came up with an idea of quantifying what he called the average man. And he realized that using the body weight per se wasn't the correct way of doing it, and that he had to normalize that weight to the person's height. That's where that concept came. So it was a population indicator. He never designed it for individuals, Subsequently, other people found it useful. There was a famous American physiologist called Ansel Keys. He's famous for the K-ration diets during World War II. Realized that he could use this measure to study obese populations. So it was Ansel Keys who actually coined the term body mass index, So it doesn't tell you the difference between men and women, for example. It doesn't distinguish between older people and younger people. So as we age, we accumulate more fat, even if our weight decreases. The BMI doesn't tell that difference. It doesn't distinguish between body fat and how much muscle you have, So there are deficiencies there. But having said that, across populations, it's still a useful marker to have. There are other markers you can use, like just using a tape measure to measure the waist size, right? That's also very useful to do. We also know that some population groups, like people of Asian ancestry, for example, may have different amounts of fat corresponding to BMI. So for example, if you take the average American, BMI greater than 30 as obesity, somebody from Southeast Asia, their cutoff is closer to 28, for example. So there are subtle differences like that. But having said that, it's as good a measure as we can have, short of going and putting somebody in an MRI machine or CAT scan, which we can't do, right? So in the clinic, you use a BMI, you use the waist measure, and then you look at the clinical measures you have and then make an assessment. So it's still a useful measure despite all the deficiencies.
Dr. Guarda, do you want to add to that? How do you think about BMI on the low end of the spectrum?
Yeah, I think the point you're making, Keri, is very important, that it is, you can't see it as an arbitrary cutoff. You need to individualize it. So we do look at, for instance, family weight history, personal weight history, recent change in weight, like a drastic change in the past 6 months to a year is usually a red flag for us that something might be happening with eating behavior. But for kids, for instance, we look at growth curves in order to see what the developmental trajectory of a specific child is. But actually, Rexford, I want to say that you just taught me something. I had no idea Ansel Keys was the person who first came up with the BMI. And that's of great interest because Ansel Keys is known to anyone in my field because one of the studies that we know the most about anorexia nervosa from is a study called the Minnesota Starvation Experiment that was done by Ansel Keys following the Second World War, when, a lot of Europe was starving, really at anorectic weights, but they obviously did not have anorexia nervosa. There was a food shortage. And so there was an interest in the US in understanding starvation, and Ansel Keys actually starved males a number of 20-something men who were conscientious objectors to a BMI less than 18.5. And we know more about anorexia nervosa from that study of starving men in Minnesota than from anything else that's been done since, because those men developed a lot of the behaviors and what we call the phenomenology, the symptoms of anorexia nervosa, although obviously once the experiment ended, they ate and returned to a normal weight, which they didn't have the psychological aspects of the disorder. But they started to, they thought and talked and dreamed about food all day, which is what we see in patients with anorexia. They're very preoccupied with food. They just won't eat it. It's not like they're not hungry. They're actually very hungry. These men also, those who were the most active at the start of the experiment, the most athletic ones lost the most weight, which is what we see in anorexia, that often the disorder starts by joining the track team. It doesn't start with deciding I'm fat and I want to lose weight. And these men also developed a lot of rituals around eating very slowly, dicing the little food they were given, and separating foods out and eating one item at a time. And these are all behaviors we see in anorexia. Therefore, many of the symptoms of anorexia, increased exercise, food rituals, preoccupation with food, are really a function of the starved state. They're not specific to the psychiatric disorder per se. And they get worse. They kind of feed forward. They escalate over time, like addiction. So that there are changes that are arising from starvation that serve to perpetuate the psychological aspects of the disorder too. So I'm kind of, you just taught me something, so I'm glad that BMI actually brings together both ends of the spectrum through Ansel Keys.
Fascinating. Okay, so let's dive a little bit deeper for 1 second on something you said, where it sounds to me the way you're explaining anorexia is that there is a psychological component that potentially triggers, right? But then the starvation state creates a feedback loop, right? And so tell me a little bit more about before that feedback loop, before we're in those places of starvation with low body weight, what happens? What are some of the drivers that cause anorexia?
That's a good question, and one that we understand a lot better than we did 20 years ago. I think the best way to think about the causes of anorexia is there's not one cause, but there are kind of three buckets of causes, and they are predisposing factors, and that's genes. We know now that anorexia nervosa runs in families, meaning if you have a first or second degree relative with anorexia, you're about 7 to 11 times as likely to develop the disorder. And what it is that we believe there are a number of genes that, like there are a number of genes that may predispose to obesity, there are genes that, or to other psychiatric conditions like depression, but there are genes that make you more vulnerable to anorexia nervosa. We do not believe anyone can develop severe anorexia nervosa. We think only someone who is genetically vulnerable can. Then the second bucket is the precipitating factors that start the illness or the disorder. And there are a variety of things. I mean, the most common is to go on a diet. It also seems to have onset usually, but not always, in adolescence and primarily in girls, although certainly boys can get this too. And therefore, we think that hormones, puberty may play a role as a precipitant, that exercise, like I mentioned, starting to exercise may precede dieting. Going on a diet can be a stressor. Any stress can actually precipitate the onset of anorexia, especially a stress that affects appetite. So it can be a romantic disappointment. It can be an illness like mononucleosis that affects your ability to swallow. But anything that causes the start of the weight loss in someone who's genetically vulnerable seems to trigger the escalation of dieting and of exercise. And then, as you mentioned, over time, this third bucket of causes, which we sometimes think of as perpetuating or sustaining factors, comes into play. And starvation is one of those. So the starved state, for instance, slows gastrointestinal transit. So you feel full more easily eating less food. It also causes constipation, abdominal bloating, a whole host of GI symptoms that make it uncomfortable to eat. So often our patients are complaining about these GI problems that they say interfere with their ability to eat more. It also, other sustaining factors can include habit and learning. You know, eating is a very social activity, and it's actually something that we do in a pattern for the most part. You know, it's partly governed by digestion and the fact that we get hungry and full based on a complex system of hormones that are communicating between our gut and our brain and control hunger and satiety. But also we eat in social settings. So there's kind of we learn what foods we like. Often that those are culturally determined. You know, they like different foods in different countries because that's what you get used to. And habit plays a large role in eating behavior. And as the disorder progresses, therefore, you can also think of it as a disorder of learning, meaning behaviors become automatic and over time. And for instance, if once someone has severe anorexia, often they are starving today because they did that yesterday, or running on the treadmill today because they did it yesterday. It's no longer even about, I'm scared of gaining weight. It's just habitual. And it becomes very hard to stop that, to, for instance, eat a regular dish of spaghetti, because that's a food that I don't eat anymore. And it's just, so it's complicated, but there are both physiological consequences, physical consequences that play a sustaining role, and psychological ones, that some of which have to do with habit or conditioning.
So I think the one of the most interesting things that you said is, you know, the three buckets, but the fact that the buckets actually kind of go through time in terms of the
Yes.
And there's a heavy focus on the individual in both the psychological status, but also then the physical status that gets triggered with some of these sustaining factors.
Right. And I think that often, the common understanding is to get well, you have to understand the root cause. Why did I get anorexia? But in reality, like with addiction and with other behavioral disorders, the reason it starts is often no longer the reason it keeps going. It's that third bucket, the sustaining factors that are maintaining it. So for instance, it's not anymore about why I started a diet in college when you're 40 years old, or even a traumatic event that happened that affected my appetite or caused me to stop eating, or the coach's negative comment about my weight. It's really about, I'm doing it now because it's what I do. And in that sense, that actually is an important thing to understand when it comes to treatment, because people tend to think I just need to understand why I do it, but it's not a rational behavior. So there isn't an answer there that's going to help you stop necessarily. Not that it's not important to understand, but it's not enough to make you stop.
So we'll talk about those sustaining factors as potential treatment targets here in just a moment, but I'd love to hear from Dr. Ahima about what are the kind of underlying root causes for obesity, as when we think about the low end of the weight spectrum and this psychological status with a genetic, sounds like a necessary but insufficient genetic predisposition that then gets triggered, and then sustaining factors. But how is that different when it comes to obesity in terms of the causes of obesity? Dr. Ahima?
Yeah, so the causes, just like for anorexia, can be parceled or divided into genetic factors. And here, the vast majority of people with weight issues, we're not talking a single gene. There are rare cases where people get severely overweight or obese because of intermarriages, right? So essentially, people who are consanguineous, right? You don't see that in this country because first cousins, for example, are not allowed to marry. But you might see rare cases in some parts of the world, like the Middle East and so on. So leptin receptor, propionmelanocortin, they are rare examples, MC4 receptor. And that kind of obesity shows up very, very quickly, right? So it's a childhood obesity. You get a huge acceleration in weight gain and so on. These children are often very hungry and very severe obesity. That's not what we're talking about for most people. For most people, it's polygenic, just like for other chronic conditions. So you take most psychiatric illnesses, high blood pressure, diabetes. These diseases are complex disorders, which are the risk factors are due to multiple genes interacting with each other. In obesity, most of these genetic factors tend to, at least when we've modeled it in mice and other systems, they are mostly in the brain, not surprisingly. So a lot of them are pathways that regulate physiologic eating, hunger, satiety, things like that, as well as hedonic eating for pleasure, right? So some of the same pathways that Dr. Guarda studies for psychiatric illnesses are also implicated in obesity, not surprisingly. Having said that, the environment plays a huge role, okay? The physical environment, the way our communities are structured, where we live and so on, how we transport ourselves and so on, play a huge role. Availability of food, right? Most people don't eat because they're hungry anymore. They eat because it's time to eat. Food is so readily available and often so cheap, right? That our societal influences drive the patterns of obesity. And then you talk about the way we are reared from childhood all the way to adulthood, the way we socialize. Food is often at the center of many things we do. So, and the environment can interact with genetic factors. That's called epigenetics. And that starts in our mother's wombs, right? So if you're an overweight or obese mother, you're likely to produce an overweight or obese child because the uterine environment overnourishes the child, okay? The environmental factors that I mentioned can also program our genetic factors in a way that exacerbates the process. If you take the natural history of obesity, most people will track upwards over time, right? Most people can lose weight, but then they quickly regain. So that's a natural history. Once you've hit a certain plateau, the difficulty becomes being able to sustain weight reduction. And most patients who show up in doctors' offices, that's their major complaint. Why can't I maintain weight reduction? And the thought is that that's regulated by a whole different set of factors, right? Which are chronic. And so it's almost impossible to go back to where you were in high school, right?
Right.
Even for the thinnest person across their lifetime, they might gain easily 5 to 10 pounds. That's a given, okay? And then most people who lose weight will regain the weight very quickly within 6 months to a year.
So treatment targets then get really complicated.
That's complicated. And these trajectories need to be borne in mind, right? You need to ask yourself, how rapidly is this person gaining? What are the factors that you can identify? Most times it's diet, not surprising, right? Issues around food quality, the social aspects of eating. Are they eating the wrong foods at the wrong times? Issues about their lifestyle. Are they eating too much dinner? Ideally, you want to eat at the peak of your physical activity. That's how most mammals eat, right? Most mammals during the day. So if you're a lion, you're going to hunt for food. So you get the food when you're very active, not when you're dropping asleep.
Right. So
in our modern societies, food is so abundant that we tend to overeat towards the end of the day, towards the night period, which is never a good thing because our physiology was never programmed that way. So it's better to eat healthier in the active period, more during the morning up to midday, and dinner really should be the smallest meal in order to align better with our physiology, right? Physical activity is also important. You need to expend energy. So most of us are very sedentary. We don't walk around. We don't do physical manual labor anymore, right? And then you add on the social environment. Most people don't even know how it feels cold anymore, right? We're all in air-conditioned rooms and a lot of heat and so on. We wear clothes. Okay, so our physiology over generations has really changed, right? And all these, if you put them together, predisposed to weight gain and excess weight gain, which we call obesity.
So let's talk about then a little bit about what we don't know about causes of these conditions. It sounds multifactorial, but kind of where's the cutting edge research right now about what we don't know about what's driving some of these conditions? What are the things we want to know? Angela, do you want to start with that? What do we not know yet about anorexia that we're really trying to figure out?
Well, anorexia is a really puzzling condition in the sense that kind of what I said earlier, that it doesn't seem rational to the outside observer. And some of the more interesting recent work is really looking at why it has this driven quality, this kind of addictive feed-forward quality. And so I think, some of the interesting work that's coming out now is really showing that there are, Rex referred to two systems that control eating. One is what's called the homeostatic system, which is this hunger and satiety signaling between the gut and the brain. And the other is the reward system. And it seems as though in anorexia, there is an alteration in both those systems. For instance, if we measure hormones that have to do with hunger and satiety, they are altered in the starved state. They do seem to go back to normal in most cases, but we think that some of these alterations may sustain the behavior. But the other thing is that there is a rewarding quality or a motivated quality to this disorder that seems to involve a dysregulation of reward. For instance, food should be rewarding, but in anorexia, it appears that all exercise and the sense of not eating is rewarding for reasons that we don't understand. There's a very interesting animal model of anorexia called activity-based anorexia in the rodent. If you take certain strains of rats or mice and you put them in a cage with a hamster wheel and you limit their food to significantly less than they would eat if they had free reign of rat food, they will start to run on the hamster wheel and eat less than the food you gave them and will run themselves to death, starve themselves and run themselves to death within about 2 weeks. Some animals are more susceptible to this than others, and that appears to be genetic. Certain strains are, and even within a strain, you can identify prone versus resistant animals. So obviously these animals aren't feeling fat, right? But they are mimicking some of the elements of anorexia that probably contribute to this kind of difficulty just saying, okay, I'm going to stop doing this now. Wow. And so some of the animal work is very interesting in trying to clarify what is in that third bucket. And there's neuroimaging studies that are really looking at what areas of the reward circuits in the brain may be altered in the response to rewards, including food. And then, so I think those are kind of two areas that are definitely of interest and that may help us understand the disorder better and understand how to change it. Then the third area is really looking at anxiety and fear and whether because patients really appear very anxious about not exercising or about eating foods that are high in calories. And anxiety disorders are very common in individuals who are at risk for anorexia. So we see them as the most common, what we call co-occurring condition amongst the psychiatric illnesses. And there is therefore an interest in also looking at the fear circuits, both the reward circuits in the brain, but the fear learning, because it's as though patients develop like a conditioned fear of eating higher calorie foods. So those are kind of three areas that I think are currently very of high interest in the field, as well as obviously trying to understand what genes are risk genes. And again, like with obesity, we know that this is a polygenic situation, meaning there are probably a lot of genes that confer small amounts of risk. And if you get a bunch of them, you're going to be at higher risk.
Yeah, it's going to fill that pot. Rex, is this also happening on the other end of the weight spectrum, kind of the focus on the brain, or are there other hot areas of research for obesity? I know some of the research that I've been seeing a lot lately does have to do with the structural factors of just access, right? Access to fresh fruits and vegetables and food deserts and, greater access to higher caloric, cheaper foods, resulting in concentrated obesity epidemics among individuals of lower socioeconomic status. So where are those kind of active areas of research for what we still need to know and learn about obesity?
So there are huge overlaps between the knowledge gaps and what we should be doing. So when it comes to obesity prevention, there's no doubt that working at societal and environmental factors plays a huge role. So you mentioned food deserts, right? A lot of underserved communities, unfortunately, bear the brunt of our poor food policies and the way we design environment and so on. And there's no doubt that if you are in a community where you have no access to good quality food, the alternative becomes bad quality food usually. And on a population basis, predisposes a lot of people to obesity, right? You see that in our school systems, the way we feed our children and so on. With the same amount of money, could we be doing better? providing more nutritious foods and so on. Transportation, right? The way our workplaces are designed. So on a societal basis, these are big ways to prevent obesity. Mm-hmm. Then you come to the individual who is struggling with weight gain and inability to sustain weight reduction, right? So that's an individual level. And the field recognizes that we are different, right? And so you get into, and the reason we know that is people respond differently to different therapies. So that means there are subgroups of patients that might respond differently. We're getting hints of that with some medications which work. More recently, a group of medicines called the GLP-1 agonists. They're usually used to treat their gut hormones. They target gut hormones. Used to treat diabetes, but if you give a slightly higher dose, you can reduce weight. They work in the brain to do that. Some patients respond extremely well, arguing that maybe their pathways are linked to this GLP-1. And some patients respond very, very well to bariatric surgery. Again, looking at the gut and the brain connection, right? Some patients respond reasonably well to drugs which work in the brain, like Contrave, which is a combination drug, or Kisimia, things like that. So the push is for people struggling with weight gain as individuals and weight reduction and being able to maintain that, there's a need, and people are recognizing that we need to be more precise, okay, to understand whether there are subclasses of people who might respond to medications differently. It's no different from the way depression, for example, is treated. Okay, within the first 12 weeks, you can usually find out if a patient is going to respond to a certain medication, right? And I suspect that's the case with some types of obesity.
Interesting. So let's spend just 2 minutes before we take some questions from the audience. If you have questions, be sure that you type them into the box that's below our broadcast, and we'll field those questions in just a moment. But just quickly, give me the nutshell about treatment. So Rex, you had just noted this is complicated and that we need to do a better job at thinking about which treatment is going to work best for which individual. Are treatments readily available to everybody? Do people know how to access treatments? And how long does treatment take? Rex, do you want to start?
Yeah, so just broadly, it starts, you treat something if you recognize there's something wrong, right? Unfortunately, some health providers, very few, fortunately, but the broader society is still struggling as to whether obesity is even a condition that's treatable, right? Some people don't recognize it as a disease, just like they would for, say, diabetes or other chronic diseases. It is a chronic disease. We know many of the causes, and we know many of the pathways, and there are treatments available. So for patients struggling with weight, the therapies are basically threefold. One, we need to work on the nutrition part of it. I'm not even going to use the term diet because it's often misconstrued. And we're talking healthy nutrition, having the patient gain better insights into their relationship with food. Emphasis on healthy foods. In my book, healthy food is a diet which is very rich in vegetables, good oils, nuts, seeds, things like that. Healthy protein like fish, white meat, sparingly if possible. Almost no red meat, okay, in my book. Physical activity is very important. Don't go running, don't go jogging. Nobody's asking for that. Just walk briskly, at least 30 minutes a day, 5 days a week. For most people, that's good. It's good for your heart, it's good for your body. And then for people who might benefit from medications, they are not great yet, but they are available. So there are medications which work on the gut. I mentioned GLP-1 receptor agonists and other central acting agents and so on. And for people whose BMIs are greater than 40 or 35 with severe comorbidities, right, like diabetes, sleep apnea, and so on, they might benefit from surgery, right? It helps some people. You can't easily sustain 100 pounds of weight loss with just medications. So where necessary, surgery is an option. So there's help out there. And a lot of people can live with obesity. There are great examples of great people who are obese. We all know Winston Churchill, right? He was obese. He lived to be early 80s, right? A lot of his peers died early. People laugh at Howard Taft, right? He was the butt of jokes. The reality is he lived longer than George Washington, even though he was more than 300 pounds. So being obese is not a death sentence. It can be managed, right? And a lot of people can live reasonable lives with weight issues.
And Angela, what about anorexia? Treatments, long-term, short-term, accessibility?
So, like I said, anorexia is what we think of as a motivated behavioral disorder. You kind of act your way into it and you need to act your way out of it. So the treatments that work the best are behaviorally oriented. And they have to first reverse the starved state, because starvation sustains a lot of both the physiological complications, but also the psychological characteristics of the disorder. So reaching a normal weight or a normal BMI range is very important. But the other thing that we see is that patients have often really limited the number of foods or the types of foods that they eat. So broadening the food repertoire and helping patients not be scared of eating a balanced, healthy diet, like Rexford's saying, but with a mix of foods of different calorie densities at regular meals is very important. To avoid skipping meals, for instance, to eat on a regular schedule, and to eat in social settings. Many of my patients have stopped eating with anyone because it becomes they're too self-conscious or embarrassed. They don't want people to comment, and they want to prepare everything they're eating in order to know exactly what's in it. So the treatment, usually a lot of patients benefit from outpatient treatment, meeting with a skilled therapist, and types of therapy, including cognitive behavioral therapy or exposure-based therapy. But some patients will require inpatient treatment in a specialty program, and access to treatment in general is unfortunately very limited. Believe it or not, very few mental health providers and frankly, very few physicians have much training in the treatment of anorexia. And right now there is a very high demand due to, in part, the COVID pandemic, which has resulted in a marked increase in cases of anorexia nervosa in adolescents, new cases, but also in worsening in individuals who have had chronic but not too severe anorexia. Access is also limited by insurance, and there has been a privatization of most treatment programs over the past 20 years that has made it difficult for care to be available to the publicly insured and to patients with the most severe cases of anorexia, since they require a lot of medical monitoring or backup that cannot be provided in a private fee-for-service facility that's freestanding. So there is a great need for treatment. This is a treatable condition. Many patients recover. Recovery is often protracted, meaning it may take a long time to get well, but it's very important to know that everybody has the capacity to recover with good treatment, and that it may take more than one treatment to get well, but you can achieve recovery. And it's important to help patients understand that even though they're scared of treatment, that in a sense, mastery comes through practice, and confidence in recovery comes from starting to change your behavior.
So let's switch to a few questions from the audience, because there's some great questions coming in here that just dive off of what we've just discussed. Rex, if bariatric surgery does not change long-term outcomes all of the time, why go through with that treatment option?
Yeah, so great question. So bariatric surgery First, I need to define what we mean. It's a big term, right? In modern times, in the year 2022, the most common bariatric surgery is what is called a sleeve gastrectomy. So in other words, you slice the stomach and make a narrower tube, about 20%, right? You don't reroute the intestine, okay? So it's a simpler procedure to do. It's done laparoscopically, patients recover quickly. It limits how much food transits, right? The rule on why gastric bypass is where you reduce the stomach volume to a little more than a tablespoon and you reroute the intestine. So it's a more severe procedure, which tends to lead to greater weight loss compared to sleeve gastrectomy. Almost any patient that undergoes bariatric surgery will lose weight in the first 6 months to a year. It's almost a given, okay? It works because there's a physical limitation as far as the food, right? And then also you change the gut physiology. The problem, just like any weight loss, is whether you can sustain the weight reduction. So over time, some patients rebound, right? But it's certainly less than if you try to do it through dietary restriction alone. So for most patients, bariatric who need it, bariatric surgery actually is successful. And it can reduce diabetes. It can reduce the risk of, to some extent, sleep apnea, certainly their low backs. It protects their knees, right? For example, if they need knee replacement. And long-term, it definitely prolongs life, okay?
And you know, kind of bottom line is that when we're talking about treatment in almost any disease, it's very rare when you find a treatment that has 100% efficacy, works every time. Right?
Yeah.
That's just the nature of human health. Angela, can you discuss for us how we should frame healthy conversations around weight, specifically for young people? As you noted that anorexia oftentimes is triggered in that adolescent time period. So how do we frame healthy conversations around weight with young people?
Well, I think that the focus should be on more than on weight, should be on healthy behavior, like healthy, balanced eating and exercise, and with less of a kind of categorical view of weight, because the reality is, especially with young people, with adolescents, is that at that age, a very wide spectrum of weight is considered normal, because they haven't reached their full adult height and there's just more diversity within the healthy range. So the other thing I want to say on that topic is that, you know, when I was a kid, I guess, the idea was, well, if you talk about all the complications of anorexia, like if you talk about all the complications of smoking and drug use, kids won't go that direction. Well, that doesn't work, in the sense that we know that kind of you can't scare people away from doing this. I have heard so many adolescents tell me they started purging because they watched a video on bulimia in health class. So the one thing about prevention, or about thinking about how to talk about these disorders, is that really focusing on kind of talking about healthy lifestyle and modeling healthy eating is very important. For instance, within families, you know, families eating together is associated with a less risk of a number of different psychiatric problems, including addiction and eating disorders. So, we know that's important. We know that not making critical comments about weight is important. Certainly, there is a lot of stigma about obesity in our culture, but there's also kind of a belief that eating disorders are really trivial. They're kind of a lifestyle choice, but they are not, because it is extremely hard to stop this disorder. It's not just a matter of just eat. Just like it's not so easy to say to someone who's struggling with obesity, well, just diet, just don't eat. These become very driven behaviors that are hard to interrupt. So, you know, the language we use with our children, with relatives or people we care about around weight is important.
I think to that end too, when we're talking about these conditions as being on the more extreme end, there's a wide space, right? Where there's simple overeating, there's cravings. It's not obesity. It's not quite anorexia. Maybe it's an obsession with diet, but it's not a driven compulsion. So how do you know who gets to draw that line? Does that come in clinical decision-making of diagnoses? Angela, you had talked a little bit about, we look at family history, we look at recent traumatic weight loss. Rex, you had talked about understanding different measurements. So obviously there's a bigger span in between, but if someone is concerned about a behavior, about simple overeating or more of an obsession with diet, what are some steps they could potentially take? Rex, why don't we start with you?
Yeah, so the key thing about obesity is one of the few conditions where the person walks through the door and you have a diagnosis. They know they have a weight issue. You don't need to tell them, right? They've come to you because they want you to be able to help them figure out what the triggers were and what to do about it, right? And so you start off by letting the patient speak for himself or herself, right? It's very important. A good history is worth more than any lab test you can do. So you want to be able to understand their relationship with food, what they are eating, okay? Yeah, there are all kinds of tools, questionnaires that are available. These can be done remotely in a patient's own privacy, right? And the information can come to you. Nowadays, we can even use pictures. So I have patients document what they are eating over a 24-hour period. And often they're stunned. Wow, was I eating this, right? And so you're able to look at that, relate that to their other activities during the day and help them out that way. And the other thing you can do is within the same context, get an idea about their physical activity. A lot of this can be monitored by recall. Unfortunately, most people tend to exaggerate how much physical activity they actually undergo. So it's actually easier to use remote monitoring, right? Use their pedometer or whatever to get a better sense. Their sleep wake patterns are also very important. Fortunately, now you can use your smartphone to be able to document that and get a more comprehensive picture about the person you're working with. Yeah. So that's the only way you can help them.
Angela, what about you? Yeah. Do you kind of think along the same lines of this as if we're starting to see people in these towing towards one extreme or the other, it is this awareness building that can be helpful?
Yes. I mean, again, this is a lot of the treatments are really helping someone to change their behavior. And you kind of mentioned, where do we draw the line between a clinical condition and just kind of disordered eating? Because the reality is that disordered eating is kind of normative in our culture. It's very common. So the way we think about when it crosses into the clinical realm is really when function is impaired or when it becomes consuming to the individual. So we're really looking for a change over time, that when the disorder kind of took on a life of its own and really impaired, for instance, social activity or job or school or health. In terms of kind of, I'm sorry, your other question was what I lost.
No, that's okay, because we're actually running out of time as well. It's been a fascinating hour. We've had great questions. We've gotten to some of them this evening, but just to wrap up here, I think some of the things we've learned here is that these conditions sit at opposite ends of the weight spectrum, but both of them are complicated. They involve genetic components. They involve behavioral components. And as Rex pointed out with obesity, there's also a very healthy level of environmental and structural components. So as we've had this weighty conversation this evening, let's all remember as we care for ourselves and one another that there's much more to learn about weight changes, weight gain, low weights on the other end of the spectrum. And Johns Hopkins University will continue to move forward to ensure that we have better solutions, better treatments, and better options for individuals as we hope to always improve human health. Thanks again for being with us tonight. And thank you to Dr. Ahima. Thank you to Dr. Guarda for being with us. And we hope you have a great evening.
Thank you.
Thank you, Keri.
Thanks.